Welcome, ladies, to the Strong Mom channel. We've got Dr. Sinead DeVore with us today. I'm going to introduce her, and we are talking all about pain. Dr. Sinead DeVore is an associate clinical professor in the Faculty of Health Science at McMaster University here in Ontario. She teaches and conducts research in both the schools of medicine and rehab science. She's a pelvic health physiotherapist, and she brings her research in pelvic health, birth, and pain science that she shares at conferences and journals to us on her Instagram page. And that's what we're talking about in today's video. She is also a mom of twins. And today, doctor, I really want to delve into the pain that a lot of moms experience in pregnancy and postpartum, and how the research that you've done actually tells us that what we believe and what we tell ourselves is more relevant than our biomechanics when it comes to things like pregnancy pain, recovering from birth and C-section. So ladies, I want to repeat that. Dr. Sinead is telling us that pelvic girdle pain, that SI joint pain, that low back pain you've got has more to do with your beliefs than your actual body structure or the function of your body or the way that you move on a daily basis. So Dr. Sinead, I know that a lot of moms are watching this and say, you are not gonna psychologically explain away the pain that I've got and I'm experiencing as a pregnant mom or postpartum mom. And you posted this on IG with the quote, pregnant picture with the quote, "Of course your back hurts, you're pregnant." And you wrote, "This is the biggest crock ever." And I think that is so funny. So let's talk about this, because many of us think that because of our back pain in pregnancy lies in our poor lifestyle habits, such as sitting too much, hunching over the computer, poor posture, and the relaxin hormone, right? That's explains everything. The relaxin hormone that makes us all loosey-goosey in our joints. But you're telling us today that your research has refuted this, or maybe shines a different light on it. And you're telling us that pregnancy pain is, in fact, lies in the psychosocial domain. So Dr. Sinead, please do tell us more about this. And the mamas who are out there saying, "But I've really got pelvic pain, and I'm seeing the chiro, and I've got a massage appointment, and I'm seeing my therapist. So you can't tell me that my pain is not real." Right, Dr. Sinead? So tell us all about your research.
Yeah, absolutely. So, first, what I would say is that comment, beliefs are sort of more relevant than biomechanics when it comes to pregnancy related pelvic girdle pain. I have to say, I've taken a lot of flack for that. But the reason why is because people are misinterpreting what that means.
Okay.
From my context when I say it. So let me kind of explain that first. And you so nicely kind of pulled in a lot of the things that we really do need to myth bust around.
Okay.
But let me explain that first. And let me, even before I do that, highlight that when, an academic or a clinician who's very up to date on the science makes a comment around beliefs being so relevant to the pain experience, that is not saying that the pain is psychological or in your head. So let's just clarify that first, because what we do understand is that our social context and our cognitions modulate our biology. So at the end of the day, yes, the tissues are affected. Your motor programs change. The tissue piece is relevant, but it's the end point. And so it's almost like the concept of if you had a plant that had a number of leaves and a couple of the leaves were kind of turning brown. And if your focus was only on the leaf,
right,
to restore, the integrity of the tissue of the plant, you wouldn't get very far. Would it maybe help a little bit to expose the leaf to sunlight, to spray some water right on the leaf? Sure, that would help a bit. Right. But what would be much more relevant is going upstream to the soil. Gotcha. And really getting to the root of it, what feeds the tissues. So what we're saying is beliefs modulate your physiology in such a profound way that it is your physiology and it feeds your physiology and it feeds then your tissues. So we're not by any stretch of the term saying the tissues aren't impacted or that they are not relevant or that, a massage isn't going to be helpful. It is, But if that's where you're focusing and you're not really getting to the root of it, you're just not going to get a full recovery, and you're not going to get it very fast.
Right.
Right. So that's kind of more what we're saying, just to kind of put that into context.
Great.
And then what I would also say is, yes, I've conducted some of my own original research in this area, but more of what the research I've done is actually kind of scoped and followed the history of where the data has gotten us. So it's kind of more of like a knowledge translation piece. And this is, of course, what I teach both at McMaster and then for some private companies.
Right.
But let's kind of talk about that, about, it's not all about the tissues and kind of, where it comes in with the belief perspective. Right. And what I will say is these principles I'm going to be talking about, much of them actually applies to musculoskeletal pain across the board. Okay. It's just that we have some specific contextual things when it comes to the pregnancy related piece, right?
Right.
So you're quite right. We have been led to believe that, it's about our posture, our way of lifting, this relaxin hormone making things too loose. And these are all the reasons why we experience pain when we're pregnant. And what we actually see, though, in the literature and with the women in front of us is that those women who truly are kind of presenting with a pregnancy-related ache or pain that might be more related to sort of a tissue issue, it usually resolves very quickly. Oftentimes, these women are able to say, oh yeah, my hip is a little bit sore. I think I might have overdone it. They can throw a heat pack on it, rest, and then the next day they're better. Right. Or they can kind of book a massage, they go, and after that they're better, like they're good. Right. That is actually a very different clinical picture than the 50% of women who have this debilitating, persistent pain presentation, that they get to the point that now they're extremely worried about how on earth are they going to birth this baby out because of the pain experience they're currently having. How on earth are they going to care for a baby when they can barely even care for themselves when they're pregnant because of this pain situation? They're even thinking they have to try to get off work. So we already see, like, from that clinical picture, there are all these different systems that are brought into it, right?
And what percentage you say with
so clinical? It's 50% of women have pregnancy-related pelvic girdle pain. Right. And when we're talking about pregnancy-related pelvic girdle pain, we are talking about this group that has this highly sort of debilitating, the pain isn't going away from when they see their massage therapist. Their pain, right? This is what we're talking about. Because the other group of people who kind of have the odd ache or pain, or they go to the massage therapist and it works. They only need like a session or two, then they're good for a couple months, then they go again. Yes, likely that mostly is a nociceptive input. And that can be taken care of with our traditional methods, but that's a small proportion of people, especially those people coming to us saying, no, I've literally had this pain since my 16 weeks. And now they're 24 weeks. Right. Like, this is what we're talking about. Right. Those are the people where the peripheral strategies aren't going to cut it. So yeah, the longer you have this situation, for example, with the plant that has a couple leaves going brown, now more are, well, now it means there's just more remediation we have to do with the soil, right? So we probably have to get water and maybe special plant food and really get that out into the sunlight. And maybe we actually have to start getting some other supports to support the leaves that are kind of coming down. Like, there's just more that we have to do. Right. So the same goes when we have a manifestation of dysfunction in our tissues that's persisting like that. We have to think, oh my goodness, now our systems and our pain system, it's designed in a way really to protect us. But when it's maladaptive, so when it's kind of been going on and it becomes hypervigilant for too long, it gets better at doing that. So it gets even more sensitive. So then your brain starts to interpret tasks that really shouldn't be interpreted as a threat, as threatening. Anything that is stimulating the mechanoreceptors of the tissue, now the brain is going danger, danger, danger. Right. And then an output of pain comes out, right?
So before you've done it.
Even before you've done it, because the brain is set up with pain to actually be pretty smart and anticipatory, right? So if you were walking down a dark alleyway and you got mugged, right?
Mhm.
Your brain is going to remember that context.
Right.
And whenever you are walking down a dark alleyway again, if you hear a sound or if something happens, your brain is going to go into danger mode. Nothing's actually happened. You hear footsteps behind you, your brain is going to go into danger mode, even if it's your best friend behind you.
Right.
Right? So the brain is anticipatory, and it's like this for a reason, to protect us when we think of evolutionary biology. But the problem is when we don't understand the other factors that are driving up this
Mm.
hypervigilance,
Right.
we can get really stuck.
Right.
And that hypervigilant state can get driven up when we're not sleeping very well.
Mhm.
It can get driven up if we're thinking, my goodness, I'm really actually scared of this upcoming birth. And actually, one of the things we see is there's huge literature base highlighting, the fear around birth.
Mhm.
In our culture, unfortunately, the way we do birth doesn't align with the research, and that's a whole other conversation. And even the way birth is kind of displayed from a media perspective, it is displayed as something that's scary, that's
Yeah.
painful, that's medicalized,
Right.
that's frightening, right? And so
Mhm.
we're starting to see, yeah, pregnancy related pelvic girdle pains. I'm not talking about the aches and pains that are easy to correct. I'm talking about this other manifestation that happens much more predictably in the second pregnancy versus the first.
Right.
It's another reason why we can kind of look and say, okay, well, if this truly was about the mechanics, if it truly was about relaxin, if it like, it would probably affect all women, and it doesn't.
Right.
It would have probably affect the first pregnancy, second pregnancy, third pregnancy, fourth pregnancy the same. It doesn't.
Mhm.
It consistently doesn't impact the first one the way it does subsequent ones.
Right.
We know when we look at the clinical practice guidelines from 2017 that a clear risk factor for this pain is a previous trauma.
Mm.
Well, we also know that 68% of women, when we kind of triangulate all the data, really do report some form of trauma, be it either physical or emotional, after their first birth.
Mm.
Right? So we have to start understanding, well, how does the threat response system actually work? And what actually produces a pain output in the first place? And this
Right.
is just general pain science.
Right.
And that science has morphed, huge in the last decade. And then when we apply that to, yes, well, it makes sense, this context of trauma and hypervigilance and
Mhm.
pain output, and lowering the threshold that the brain would interpret threat,
Right.
and a previous birth trauma. And when we think too of women who are actually going into their second pregnancy, and we think of their energy system, I mean, these are women usually who are caring now for a toddler,
Mhm.
who weren't nearly in the sort of state of physiologic reserve going into that second pregnancy as they did their first,
Right.
because they went through all the depletion in the postpartum period of being sleep deprived, breastfeeding. And I mean, once you're a mom, like, you're on,
Yeah.
like, you don't stop,
All
right?
the
And
time.
all our listeners, right, can resonate with that. You are on. So even if you feel like, yes, you've kind of gotten back to your routine, you've gotten back to work, you've gotten back to exercise, you've gotten back, still chances are you're not nearly, have as full of a tank that you did before that first time.
Right.
And so, when we think again, the threat response system goes off more when our energy is low, when,
Mhm.
when our tank is low. So there's another classic reason, but oftentimes women aren't thinking about their energy system and what is that actually doing to their threat response. Once your threat response goes off, that actually does change your motor output.
Right.
So it will change how you move.
Right.
And so, yes, the mechanics are relevant, but not really the way we've thought. It
Right.
really isn't about correcting upslips or downslips and let's get you just more stabilized. And no, we certainly want to improve motor strategies.
Mhm.
Absolutely. We
Mhm.
know there's a lot of co-contraction. We know that there's a lot of pelvic floor high tone, because that
Mhm.
is a highly protective muscle that's
Right.
connected to our threat response system. And if our pelvic floor is locked like this and can't properly participate, in the collaborative dance with the transversus abdominis and the lumbar multifidus and the diaphragm, I mean, forget it. Your motor programs are going to be off,
Right.
right? So, I mean, this very much, just to kind of kick us off, and then I'm sure you'll have follow-up questions. This more is the basis of what we're talking about. So
Mhm.
it isn't to say it's in your head and it's all psychology. Absolutely, it lands in your tissues.
Right.
It's just we need to contextually understand how it's in your tissues, and we
Mhm.
need to travel back so women understand about their sleep, about their energy system. Are they trying to exercise, at the end of the day when their energy system is done and now they're wondering why is it painful when they walk? When a simple change of go for your walk first thing in the morning.
Right.
Energy system is good. Your mechanics are the exact same. You are
Mm.
going to find it's a totally different experience in your body. And
Mhm.
it's just helping us to understand we need to think of all the systems. And does that mean there for sure isn't any reason to maybe go to a chiro or physio? Of course, absolutely. Go to those people. There is going to be an impact on the tissues, and for
Mhm.
some people more than others,
Mhm.
but don't get distracted there. And when
Right.
you're going to your chiro and you've been going there now for 12 weeks and you're getting like a day's relief from your symptoms, and then you're feeling like you need to go again, I mean, that's a clear sign that you are not getting to the root of the issue. No one should have to spend that much time in a healthcare practitioner's
Right.
office. That's
Right.
crazy,
Yeah.
you know? So yeah, that's probably where I'll just stop momentarily because I'm sure you have follow up.
Yeah. And I think you're right. Like people will say, I have to go to the chiro because she fixes me.
Mhm.
She makes me feel like this, right? Or I'm trying to get to this result. And so
Right.
we put our trust in that practitioner that yes, they can help us, but it also comes within us, right?
Yes.
So
Yes.
what are some of the things that you get your clients to do that's within them, right? Sleep,
Mhm.
movement at,
Mhm.
change around the times of the day. I know you talked about some of the other psychosocial factors were lack of job satisfaction,
Mhm.
smoking. We talked about the trauma, and lack of expectation for improvement. I
Yes.
think that's a big one. And I
Mhm.
see that with my clients too. Oh, for example, I gained 10 pounds again, and that they're just kind of stuck, right?
Yeah.
And that
Yeah.
keeps them stuck. And we can,
Yeah.
relate that to the pelvic girdle pain as well. Oh, I have this pain and it's been like this for 12 weeks. I'm not going to do anything about it.
Right.
So how do you help your clients, and how can we talk to the moms out here? How can we, I don't want to say get it out of your head, but what can we do to help ourselves?
Yeah. And this is honestly where I feel like trainers are such powerful allies in this space, connecting with women, working with women. You already have such a great sort of therapeutic alliance and a degree of kind of trust. And really, these people are interfacing with you usually
Mhm.
because of their desire to want to move, right?
Right.
But just them feeling like, yes, but when I move, it hurts.
Mhm.
And then oftentimes that goes with the belief that that must be dangerous and
Right.
they don't want to cause damage, right? So,
Mhm.
really, where we have to step it back, and any single person interfacing with women in this space, this is within your scope, right?
Yeah.
But really, we have to get women first to understand what the pain is actually all about.
Mhm.
So it's important that we do some work there. We know that women will not change their behaviors if they don't adjust their beliefs, right? If we can't get someone to understand that it isn't damaging to walk, even though they're feeling that sensitivity in their tissues,
Mhm.
right? We're not going to be able to get them walking. Like we
Right.
just aren't. So, really, we have to kind of start at that level. And so, usually, where I start is I will kind of start around some of those things I highlighted that might sort of question their beliefs around, okay, but if it really was all about relaxing, I mean, we have data that shows us that it's not, but if it was, like if it really
Right.
was, why is it that it only affects this many people?
Right.
If it really was, why is it that many women have no issue in their first pregnancy and they do their second pregnancy? Like if it truly was about, truly the mechanics of your size and the weight, if it was about the weight and the mechanics and relaxing, we know mamas who are pregnant with twins, and that of course was me, have over threefold the amount of relaxin. And they have over double the weight because in many cases, I mean, I had two babies, two fluid sacs, two placentas, two, and so why is it that that group actually has less pregnancy related pelvic girdle
Right.
pain? So sometimes by presenting some of this information, and this is
Mhm.
why it's critical that trainers are informed
Yeah.
and they do have this knowledge. Because if you say, like, if it really, like, how do we explain that? And how do we explain right now? I want you to walk forward 5 steps and then I want you to walk backwards five
Mhm.
steps.
Mhm.
And oftentimes we find walking backwards, it's a totally different experience.
Yeah.
Usually the brain, it's a novel movement, isn't anticipating that that's going to be threatening.
Right.
And so the tissues don't automatically get that extra degree of tension and sensitization in them.
Okay.
You don't get that kind of hypoxic reaction of less oxygen, right? Because nothing constricted. And so then it doesn't hurt. And you say,
Right.
like, how do we explain that?
Right.
And so you really do, I believe, need to kind of highlight, well, if we have this, then how do we explain this? If we
Mhm.
have this, how to get people thinking a bit outside their box and maybe
Right.
starting to get them to be open to buying in. But
Mhm.
most people won't buy in until you change their experience.
Right.
So this is one of the first things after I'm done engaging with someone, they're in my office, or even if I'm doing it virtual, I can kind of talk them through this, right? Is I get them to do movement that they can literally experience a dramatic change in their body that questions then their beliefs. So
Okay.
if they're coming in and saying, well, no, I know it's just that my core is weak, because as you said, women are so good at shaming themselves, right?
Yeah.
I didn't get onto my exercise plan after I had my first baby. Like, I didn't go back to exercise. I know my core is weak. I didn't properly restore my pelvic floor after my first thing.
Right.
So I went
Exactly.
and I know my core is weak. And we know that this has nothing to do with core weakness. I'll say it again,
We're going to
nothing
talk
to
about that
do
in a bit.
with core weakness. So yeah, so we'll come back to this because that's a big one, right? But women think it, right? And they'll come in. So, we know that if truly we are going to strengthen and develop fitness in tissue, that does not happen in 5 minutes,
Yeah.
right? That takes like weeks for that to
Right.
happen, right?
Right.
So, a powerful way to sort of question that belief, or have a woman start to question, maybe I do need to think about this differently, right?
Mhm.
Is by getting the pain experience to be dramatically different within the session. And this is absolutely something trainers can do.
Yeah.
So, the walking is one thing, but
Mhm.
another thing I will often do is I'll have the woman lying down and they'll do what we call an active straight leg raise test, right? And this is a test that many trainers do as well, right?
Mhm.
And really, we're looking at the woman just lifting up their one leg, lying on their back. And what we're trying to determine is, how easy was it to do that? Right? With how much ease did you do that? And oftentimes, women who have pregnancy related pelvic girdle pain, they have so many motor patterns that are off, so much co-contraction, that a task like that is difficult to do. It's like your leg is lead,
Right.
right? But then when we say, okay, how easy was that to do? And oftentimes we'll be like, that was hard and that hurt. Like, that pulled my sacroiliac joint. So they'll have that experience. And then if I say, okay, well, why don't we kind of do some movement and then we'll do that again? And I have a very kind of specific novel movement sequence that I do with clients where, they're thinking about their breathing, they're
Mhm.
bringing their legs into butterfly, they're coordinating that with a few repeated movements that are gently engaging the lateral structures of their hips.
Mhm.
Then they move to some movements coordinated with their breath that they engage sort of the medial structures of their hips.
Yeah.
So it's very deliberate in terms of what I'm doing,
Mhm.
but I'm
And the
also
way that you
getting.
say it just makes me feel like this.
Totally. And I'm right there with them, either on the screen, talking them through it. So they're usually feeling pretty safe. They're thinking, oh my goodness, she's asking me to go into butterfly. Like, I was told to keep my legs together. And so,
Yes.
like, even that's a bit of a, okay, but I
Yeah.
sort of trust this person. So, okay. And if I'm there with them in person, it's even better because I can kind of have my hands on them and guide them through. So we take them through this very basic sort of sequence that takes a couple minutes. And I say, okay, so let's now just kind of try to lift that straight leg raise up again. And it's dramatically different. And that then is oftentimes sort of a bit of a linchpin for them to say, oh, wow, I'll say, see, so absolutely, we changed how your muscles were behaving for
Right.
sure. Your
Right.
muscle behavior is part of that,
Yeah.
right? But it's not because it's inherently weak, because we didn't strengthen you in these 5 minutes. We
Mhm.
put different inputs into your system. We created safety. We brought oxygen on board. We did a whole bunch of things that then actually your tissues could behave in the way they're meant to,
Right.
right? We got a lot of the barriers out of the way
Mm.
because really that's what we have to do. You made an important comment before, Denise, around for the most part, when women are given some guidance, and some of that guidance can involve some safe hands on touch, that will help motor programming for sure. Some of the guidance is movement, some of the guidance is better sleep, right? So, yeah, guidance I think is important. Women shouldn't be told they have to figure this out on their own.
Right.
But with guidance, what really is needed is everything they already have inside. It's
Mhm.
just a matter of removing the barriers and kind of nudging them down the right path.
Right.
But then they have everything there already,
Mhm.
right? And this is why I feel like the best people to help women in this position are really practitioners and fitness providers, very much coming from a coaching perspective
Mhm.
and not a fixing perspective.
Right.
So when I'm engaging with pain, off goes my kind of traditional practitioner hat and on goes my health coaching hat,
Right.
right? Where
Or
we're really working alongside, right?
right. Right.
Yeah. So, I mean, I really do think, yes, the first thing you need to do is flag and help them to maybe see one, that their beliefs aren't correct, but two, that they're actually keeping them stuck.
Mhm.
Right. But then, talking to someone on that level often isn't enough. They need to feel it in their body.
Yeah.
They need to have that experience. So they think, oh my goodness. And then maybe they're listening a bit more. They still might
Mhm.
not be convinced
Right.
until, it's really proven to them. Right.
Right.
But
Right.
at least they might be on enough to say, okay, you know what? I'm going to make some micro shifts in my thinking.
Mhm.
I'm going to make some micro shifts in my doing. And usually that's all it takes,
Right.
micro shifts. And then they start doing so much better and so much better. And then they're coming back and saying, yeah, like here I am now at 36 weeks pregnant. When I first met you at 18 weeks pregnant, and I'd been struggling since like 14 weeks pregnant, my belief was that this issue was going to get worse and worse and worse and worse
Right.
because the moving target of pregnancy was the etiology of it.
Mhm.
And really, I was hoping at the very least you could help prevent it from maybe getting any worse and helping me to maintain.
Right. Right.
But now I'm at this situation at 36 weeks pregnant and I'm so much better than I was before.
Right.
And now I'm really looking forward to, okay, forget about how I'm going to do during my pregnancy because I've already done that well and I'm great with that. How am I going to have an amazing birth and recovery?
Right.
And
Right.
then we can kind of shift our thinking. And I
Right.
mean, the research tells us this, but I see it play out in my practice every single day. The
Mhm.
fact that I'm following this new way of understanding this issue, that again, I didn't make this up, right?
Yeah.
This is what all the literature says. It's just so incredibly effective. And every single PT trainer, doula, midwife who takes my course and starts applying this, I mean, I'm getting emails all the time of, oh my goodness, it's so incredible that it's so much less complicated. It's so much more empowering and
Mhm.
it works so much better, right?
Yeah. Yeah. So how would one, and you work one-on-one with moms as well,
Yes,
right? Like you said.
yes, yes.
So I guess my next question was going to be, how does one find a practitioner like
Mm,
you who has this knowledge and of the beliefs, right? And so I think moms will go to maybe a chiro or a physio, and like you said, try to find somebody who is maybe holistic or
yes,
kind of in nature, or a health coach, something like that, who has a more holistic view and not just the pain and I'm going to do this.
yes, absolutely.
Right.
So this is a great question, like really and truly, because not every doctor is the same. Not every OB is the same. Not every midwife's the same. Not every trainer's the same,
Mhm.
right? And it unfortunately does put some onus on us as the health consumer to make sure we are connecting and spending our time
Mhm.
with the right type of person who's
Right.
actually going to take us across the finish line fast and properly and effectively, right? So, a couple of things I would say on that line is, I mean, certainly if you are in the Canada area, Pelvic Health Solutions
Mhm.
is probably one of the lead, certainly not the only, but one of the lead, I'd say, training agencies for pelvic health
Yeah.
physiotherapists, right? So if you're thinking in your mind, pelvic health physio is kind of someone you want to interface, and I would argue that would probably be a very useful person to address part of this problem,
Right.
right? And actually to address a whole bunch of things that might be going on in pregnancy to prep for birth and recovery. Because really, we don't treat conditions. It's not like I treat pelvic girdle pain. I care for women, and women might be coming with, frustrations around this awful pain experience, but they also want to prevent themselves from getting diastasis. They also, they come with all these things, and I'm going to help them with all those things, right?
Right.
So there'd be a lot of reasons why, a pelvic health PT, and a good one, might be part of your team, right?
Yeah.
But you really do want to make sure you have someone who has a lot of pain science courses under their belt. And the nice thing that Pelvic Health Solutions does that I don't believe any other listing agency does is they list the courses that these PTs have taken.
That's what I love, that site. Yeah.
Right. So you can kind of get a sense of, well, is this a pelvic health PT that literally has just kind of taken their level one, their most basic training to be allowed to call themselves that? That's going to be quite different than someone who has been doing this for years, has all the pain science, has all the pregnancy specific courses, has all. So that's one way of teasing it out. With the other provider groups, what I think is oftentimes a great litmus test is really honestly how they're even going about their sort of what we call like the subjective, the interview part with you. You'll get a good gauge based on if it feels like they're asking just a lot of closed-ended questions. They're not asking a lot of open-ended questions to really understand your context. Right. Well, what about the sleep? And what actually went down in that first birth? Like, tell me about it. Like, we have time. Tell me your story. Tell me about it. If you're working with a practitioner who's not doing that, and it's a lot of closed-ended questions. And when you're talking in terms of this really being an issue, primarily speaking about musculoskeletal mechanics, and there's no dialogue to even attempt to explore the other factors, to me, that would be a bit of a flag. And does it mean that you won't get something beneficial out of that one encounter? No, you might get something useful out of that one encounter because you will get sort of a fixer mentality right on the tissues. But I would say then you've probably extracted all the benefit you're going to need. And there's really no need to circle back with that individual again. Right. So that's probably what I would say about that. I think that's probably your best bet and your easiest bet when it comes to any type of pain experience. Right. And this is, we've kind of been talking about pregnancy related pelvic girdle pain, but you made the other comment about like after birth, and we've had a cesarean, and now we're having this persisting pain. It's been 4 months, and you certainly weren't expecting that, so anytime we're dealing with a pain experience, we have to be thinking about that soil and leaf analogy. We have to. And so we have to be thinking about all the systems that have kind of impacted that threat response. And it means for a clinician to be a really good coach and guide you, across the finish line, in the smoothest way possible. They need to understand all your unique context. And for them to do that, they need to let you tell them. They need to let you talk. They need to, right? And so if that's not happening, then, you know where the limitations in that encounter are going to be.
This is how we do this.